Thanks for the obvious.
Hello and welcome to Fertility Factor Fiction. Oh my God, my camera's dead. It's not on.
I don't have my mic.
Here it is.
Hello, everybody. Scrambling at the last minute here. I am your host, Dr. Ahi Victory, and this is Fertility Factor Fiction, and we are still getting ready. So, welcome aboard. I am the host of Fertility Factor Fiction with my dear friend, Dr. Tariq Ibrahim, doctor in quotation marks, because he's not a real doctor.
But I could be one day, maybe. You never know.
And we run a fertility program where we answer questions live on the internet and on multiple different platforms. And we're still working on getting LinkedIn. We got to get LinkedIn.
You got to get LinkedIn.
Mm-hmm. That's important. We probably both have a massive case of indigestion because we just wolfed down food in about.
I really wolfed it. I'm trying to walk it off.
In 3 minutes. And here we are. So I had originally intended to present data on why induction of labor is the way to go, but I don't think we have the right feeling for it now because we're really sort of super busy.
Sure.
So we're going to do that next time. We are going to discuss induction of labor and why people should be induced. And I think that's going to be really, really important. So hopefully we can get that. How are we doing? Are we good?
You look great. My God. What a beautiful ray of light and brightness.
Ray of light. I love that. So, here we are. We are basically going to take questions for people and answer any questions that they may have. And, go ahead. Anything.
You know what's really funny? For a good second, not more than a second, I said, what's supposed to happen next? What are the questions? And I forgot that I have to actually look to read them for some strange reason. Not sure what to make from that. I'm losing my mind here.
We can flip through new articles while you're looking.
No, I got them all. I'm here. I'm back. I just completely forgot that I'm looking for questions.
Sure.
I'm like, well, where are the questions coming from? All right, Dr. V, here we go. Let's start with the first one.
Okay.
40 and a half years old.
Yeah.
Very accurate age, if I may say. 40 and a half.
Yeah.
Third FET this Wednesday.
Okay.
5 PGTA embryos.
Oh, wow.
FET number 1 ectopic. FET number 2 no implantation, December 2025. HSG post ectopic normal on prednisone, Claritin, ASA, Pepsid empirically. No endo testing yet. If FET number 3 fails, what testing before next transfer? Thank you so much.
Microbiome, immune, a better look at your uterus, because I find over and over again, people are missing the fact that they have a T-shaped uterus, a Y-shaped uterus, it's a narrow cavity, things like that. So those are things we would look at. The microbiome is really critical. The immune system is critical. Sperm DNA fragmentation, if you haven't already, although it's a bit too late on that one. So these are all the things that we would be looking for.
Oh, you just really ran through that quicker than I thought. Dr. T, yes. How can I help you? The question is, I was 1.5 weeks into stims. We stopped for under response, then had too many follicles for IUI. Did it trigger last Wednesday and severe pain since, assuming from releasing all of... And the question just ends
all
right
of
there.
the eggs at the
all
same
of the
time.
eggs, yeah.
Yeah, of course it's from releasing all the eggs. So when we do that, which thankfully doesn't happen too often, but it does occasionally, we will actually bring the patients in and retrieve the smaller eggs so that we don't risk multiples, and then we're good. So that seems to work out quite well for us, and that way we don't have to worry.
You know, I always mess up on the camera. Sometimes, not always, because when we're setting it up initially, we got the nice long horizontal.
Yeah.
But the minute we go into Instagram, I'm verticalized.
So do you want me to back it up?
No, I think I'm good now. It's just I was slouching all over the place. There's no room for movement on Instagram. You got to sit still on Instagram. I apologize, grammars. I apologize. Dr. V, how are you? How you feeling?
I'm good.
You're feeling good?
I'm feeling great. You know what? We have a new CEO.
Yes, you do.
And we're going to bring her on the show soon, actually.
Great.
Super excited. And this week we introduced our new physician assistant, Stephanie.
Oh, wonderful.
And she is awesome. So
I think I was the one that came up with the idea for the physician assistant. I want to take a 90% credit.
Yeah. So you know what? She's amazing. She's super smart. She's like on everything already. She's got it. She's great with ultrasound because she was previously an ultrasonographer, so like the perfect.
Perfect.
And so I'm actually seeing a dream.
Oh, I see.
Of me having a life again.
It's not a horrible dream.
It's not a horrible dream. So I'm super excited because like I don't have to deal with the businessy stuff as much anymore.
Mhm.
Our wonderful CEO Marla is doing that, and Stephanie's starting to take over some stuff, which means I probably won't get to work less, but we won't have as long a wait list, which is awesome.
Also,
So I'm very, very excited about this. So yeah, there's some cool things happening at VRC. Our staff just keeps growing. We're now at 75 people. It's crazy. Yeah, so pretty good. Pretty good.
Pretty great.
Yeah, very excited.
Dr. V.
Yeah.
As the questioner says, if I got pregnant after lap and loop suppression, should I suppress again if I want to try after pregnancy?
If I got pregnant after
lap and loop suppression,
and loop suppression, should I suppress again before trying to get pregnant?
Should I suppress again if I want to try after pregnancy?
Ooh.
Ooh.
Good question. If you're breastfeeding, probably no. If you're not breastfeeding, then I would definitely say it's a thought, but only if it's been like a full year or two since you had your pregnancy. Not if it's immediate. You probably don't need it.
Dr. T, we're at your scrubs. Still looking good. You guys are lucky to even see me today. Let me tell you. I was going to be camera shy today, but good old Dr. V, from the bottom of his heart, he said, come on the show. Don't worry. You'll be all right. So
I wouldn't be able to do it without you.
Hey, man, I appreciate it. Dr. V, would you recommend removal of a 7.5 centimeter intramural fibroid, even though the saline sonogram shows it does not impact cavity? 3 failed FETs.
So first of all, a 7.5 centimeter fibroid is impacting your cavity, even if they told you it doesn't impact your cavity. So you need a 3D saline infusion sonohistogram. And then secondly, there's good data that shows that if your fibroid is bigger than 4 centimeters, it's impacting your success rates. So that's a total no-brainer. Get your fibroid out. Like, how could you possibly, not you, but how could the patient's physician let them continue with a 7.5 centimeter fibroid?
It literally reminds me of the podcast we had earlier today. That's so clear. Like just wild things being said.
This stuff I hear is just like bizarre things. Like I can't even explain them.
Oh my God. You want to hear something crazy?
Oh, sure. I love crazy.
So you know what?
I live for crazy.
So we're sitting around in a group.
Yeah.
And conversation about women and gynecological health pops up.
Sure.
And of course, who is summoned? Dr. T is summoned. So, you ready for this? This is real life.
I am absolutely ready for this.
So I want you to know, I actually gave a conclusion.
Yeah.
But then followed it up with, you may also want to see a doctor about this, because I'm not 1,000%.
Okay.
But I'm pretty sure I'm good.
Okay, I'm all ears.
You ready? I got you. I got your interest, right?
I'm all ears. I am in. Yeah. Leaning in for you, buddy.
So I'm hearing the story about an individual, and they have when they get their period, they have very heavy periods. Okay.
Yeah.
So lady goes to the doctor, and the doctor says, I know how to deal with this. All you need is an IUD, and you'll never have your period again. And the person's like, no, that's not my problem. My problem is I have heavy periods. I don't want to not get a period. And they're like, no. This is the only solution for you. What do you say about that, Dr. V?
The only solution?
The only. Our fun word. The only.
like only IVF.
Only IVF.
Yeah,
That's right.
there's probably 50 different options there. Like, what the hell? How about let's get a diagnosis first?
So I actually said there must be something wrong with the blood work. There must be something wrong inside with you. Again, I'm not a doctor. I'm just
Yeah.
privy
Yeah.
to hanging out with a
You've been
doctor.
hanging out
But I've
with
been
us.
hanging out here quite a
Yeah,
bit.
yeah,
So I
yeah.
said there's something there must be something wrong with you.
Yeah.
Maybe you got endo even. Maybe you have some
Maybe.
underlying thing.
Yeah.
So for sure, I don't see how the IUD is actually the solution. And she says, you sound like a doctor. Just want to put it out there.
Yeah. So there are many. There are you should by now you should sound like a doctor.
That's what
I'd be disappointed in
you know
by
what?
now if
Thank you.
didn't sound
Thank
like
you
a
for knowing the
doctor.
truth.
Yeah.
Absolutely right. Absolutely.
So there are probably
a million different things.
So first of all, let's just talk diagnosis: hormones, ultrasound, some vitamin levels, bleeding disorder stuff. Like there could be 50 different things, right?
Mhm.
So basic blood work, complex blood work, hormonal blood work, coagulation cascade, coagulation factors, liver function. All of these play a role in how you bleed. Then you got to do an ultrasound: fibroid, polyp, endometrial thickening, funny shaped uterus, whatever. All of these would be important. And then you need to do a saline infusion sonohistogram where you make sure there's nothing inside the uterus that's causing the torrential periods. And then you get to go through options. Nothing, NSAIDs, which reduce bleeding, procoagulant things like tranexamic acid. Then you've got a whole regimen of hormonal things that you can do: birth control, IUD with progesterone in it, progesterone, various delivery mechanisms. Then you talk about the anti-hormones, so the things like Lupron, the GnRH antagonists like Myfembree or Alyssa. You've got your specialized progesterones like Vizan or Depo-Provera. And then you've got like the more harder hitting stuff. And then we still have surgical options too. So this whole only IUD, it's like one out of, 20 different options for you. Like that's insane. Why do people do? Today was like a bizarre day. I got to tell you, like the stuff I heard today just blew my mind. Stephanie and I would look at each other like every time, with the highlight of probably my career being this woman that crystal clear had developed probably mild, moderate ovarian hyperstimulation syndrome just from taking Clomid, which is rare, but it does happen. It's being reported. And she called the clinic she was working with and told them and said, I've got like a significant amount of discomfort and bloating. And they told her that it was probably from the air in the IUI catheter.
Here we go.
Now,
I know that, doctor.
Now, just to put this into perspective, okay, the amount of air in an IUI catheter, at most, if you epically screwed it up and didn't do it properly, is going to be like 0.3 cc's.
Oh, wow.
The amount of air we put into doing a saline infusion sonohistogram, which is, something we do 6 to 8 times a day here, is probably like 5 cc's. And not a single patient has ever come back complaining of bloating. So they epically missed this patient's diagnosis and came up with the most irrational explanation I could ever come up with something. Tell them they got a virus, for God's sakes. But
anything's better than that. Air.
0.3 cc caused bloating?
Wild.
What the? You know what? I lost my marbles. I couldn't understand that.
Yeah,
at all.
It sounds like something to lose your marbles on.
It was weird. Yeah, I was definitely quite distraught after I heard all that. I was like, what the hell? This makes no sense. Who's coming up with this?
Well, that's what I was wondering when I heard the IUD was a solution. I'm like, that can't be right. I've never heard that as the single only option.
Just totally.
Totally only option.
Yeah.
Woman goes in, does her things, shows her blood work, IUD. I mean, there's just no way. There's just no way. Like I'm not really a doctor, but maybe I am. But
I know enough.
But I know enough to know that's completely whack. And judging by your response, sounds like I was on the right direction.
You know what? We need like some kind of symbol you can pop up on the the screen that says completely whack. We can do it on this thing too.
We can. We can design it and then just drop it in.
We need the completely whack.
We will make it completely whack.
You got to.
I love it. I love it.
You got to do completely whack.
We will make it completely whack.
We can do that every time someone comes up with like a crazy story that their doctor told them, because that would be awesome.
Somehow there's a lot of those.
I need you to have that ready for next week.
I'll have it.
We need the completely whack button.
Consider it done.
Excellent. All right, fire away.
Doctors.
Yeah.
Again, this is playing right into the ego here. Do you ever recommend a modified natural over a medicated after your endosuppression?
We only do modified natural after our endosuppression. We don't do medicated. We use a smidgen of estrogen if we have to, but like it's minimum doses, and sometimes we don't even need that. So we try and avoid it when we can.
Hi, doctors. How many times does it usually take to treat the microbiome with high levels of bacteria found on Fertility? Going to my second round now.
Yeah, it can be brutal. Sometimes it takes months. Sometimes everything we try doesn't work. We're now doing washes into people to try and get rid of the bacteria. Like it's a lot of work. Microbiome clearance is actually fairly challenging. It's not an easy thing to achieve. It takes a while. You got to put a lot of effort into it. The patients have to be compliant. Their partners need to do it. Some people are, ending up with illnesses as a result of all the antibiotics. So it's not without its like pitfalls. There's issues. You still want me to fix it?
Yeah, you know what? Can you zoom out a little bit? I'm sure there's a little bit.
You tell me when.
Yeah. Where am I? More. Go way more so I can be in the view even if I tilt. Okay, let's see how that goes.
All right.
Okay, Dr. V, we're going to Tech Talk now. The Tech Talkers are getting rowdy. I see it. I see the Tech Talkers getting rowdy. Like, he's not answering us.
By the way, if anyone is watching who had an opinion on our induction video, feel free to ask.
Feel free to ask.
I will take that stuff all day, every day. Yeah, or anyone that wants to challenge me on vitamin K. Oh my God, they're still vitamin K crazy. Someone sent me a private message, telling me how sick they were of doctors saying that there's no risks and that there clearly are risks. And I said, well, okay, what are the risks?
How's it?
Radio silence. I got nothing. I got zero. But she's sick of me
saying there's no risk.
Clue what the hell she's talking about.
Yeah.
And when challenged, she can't present a single iota of evidence, but I'm the bad guy. Like, I love these people.
Say hello to the bad guy.
I love these people. They're just unhinged. Anyways.
Dr. V. Yeah. Told it was a textbook perfect.
What was textbook perfect?
I guess her eggs or her transfer or her round, we'll call it.
Yeah.
This is the assumption. Now, I'm literally just reading it to you as I get it. I told it was textbook perfect, but lost it. Was treated for endo prior. What went wrong? I'm afraid for my next transfer.
Wow. Microbiome, immune, DNA fragmentation. I don't know if the embryo was euploid or not. I mean, there could be a dozen things that go into that one, but there's lots of stuff we can check. I mean, if you have endo and you didn't do an endo protocol, that's number one. If you have endo and you did a medicated protocol, that's number two. There's a lot of different things.
Hi. Stage 4 endo, 4 IUIs, 2 IVFs, no success, or embryos. Doc sent referral to you. Can't wait.
Wow. That's next level when we become the place of the other doctors. They're sending their patients.
Doctor's like, I'm done.
I'm done. Yeah.
I'm done.
Yeah,
Give this the victory. This is his thing.
Thank you, everybody. It's been lovely serving you. I'm officially done now. I'm out of here. We made it. Yeah, that's awesome. Well, first of all, that sucks that your IUIs didn't work. I'm really sorry. That's terrible. And it sucks even more that you tried IVF not once but twice, and neither of those resulted in embryos. What I can tell you, and I think what we've garnered a reputation for, and something that keeps driving more and more patients to us, is we just tell you what's wrong before you start. I had a lady on the call with me yesterday, because I worked a full day in clinic yesterday. Very nice couple who have a very interesting dynamic. He's a little younger, she's a little older, and they kind of travel quite a bit. So I spoke to them. We reviewed her age, which was up there, and I said, "Has anyone talked to you about your chances of success and explain the math?" And she said, "Well, yeah, they told me what my success was." And I said, "No, no, no. Did they tell you what it's going to take to get to success?" And she said, "No." So she had gone into this and she told me this. She said, "I was planning to come to you March, and then we were going to come to you again in the summer for a second round, and like we're going to make this work." And I mean, she was definitely older. And when I went through the math with her and explained exactly how many times she was going to need to make this work, she said, "Okay, talk to me about donor eggs." Like,
right away.
no one's explaining this stuff to people. They just leave them in the lurch and they're not telling them what to do or how to do it. So, in someone with really bad endo, unfortunately, you need a really honest appraisal of what your chances are. If you're stage 4 endo and you've got brutal endometriomas and they can't get either eggs from you or at least good quality eggs from you, it's problematic. And I think, maybe I'm wrong, but I believe morally the patients deserve to know what their chances are before they invest tens of thousands of dollars, if not more, to enter into something that's going to financially devastate them, emotionally devastate them, maybe relationship devastate them, physically not be the most pleasant thing to go through. These things have like weight. They take a toll on people. And to just ignore it because you want to do another IVF cycle as a clinician or as a business, like that is not okay. We are doctors. We have a responsibility to be good to our patients. We have a responsibility to be moral. We have a responsibility to actually do the right thing for people. To just keep plowing people through the same IVF cycle over and over again and then not actually make it count for something, I think that should be censured, let alone, considered wrong. Something should happen for those people because that is not okay. So when you come to me and we do a consult together, I'm going to be honest about what your chances are. I will help you your way. I will give you all the options. If you hear that you need umpteen cycles of IVF and that's what you want to do, I'm your champion. I will walk you through it. But you deserve to know it's going to take X number of cycles. It's going to take this long. It's going to require this. And this is potentially how much you're going to have to spend to get there. Because if I don't do that for you, it's not that your body's failed you. It's that I have. Because I didn't tell you the right stuff.
Dr. Victory, following up to the almost exact same type of question.
Okay.
How many times does it usually take to treat? Oh, sorry.
We did that.
For endometritis,
Yeah.
do you recommend doing a biopsy or just taking doxycycline?
Oh, dear.
My RE says just take the doxycycline. You don't even need to know.
We need to redo the M&M's video.
You don't even need to know.
We need to
just dump meds
right.
everywhere.
we gotta redo the M&M's video. Okay, so listen. Taking doxycycline is really effective at killing some bacteria, but not all bacteria. And as a general rule, the bacteria in your uterus fall into different categories that actually are susceptible to different antibiotics. So there's obligate anaerobes. They're like, generally sensitive to Clinda, maybe some Flagyl. You've got your facultative anaerobes. They might be more gram-positive. So you've got your strep and your staph and your enterobacter. So you can use a whole host of different antibiotics for those. And then you have your pathogen bacteria, like chlamydia, gonorrhea, and then you need to know what you're treating because you got to treat it with the right antibiotic. So if I give you doxy and you have, as an example, a high amount of Gardnerella, you're going to get zero antibiotic killing from that in the terms of the bad bacteria. But what you are going to get is all of your lactobacillus, which you need, killed off. And now the bad bacteria that were there are looking around going, let's invite our friends. There's more room now. Let's party. And all the bad bacteria grow and you just got worse. So any doctor that tells you to, quote unquote, just take doxycycline, has not read a shred of anything or even spent 10 seconds trying to figure it out. In terms of doing a biopsy has been proven to be useless in multiple studies, and it gets even better. It doesn't tell you what bacteria you have. So you're back to square one where they go, okay, maybe you do have a diagnosis of chronic endometritis. Only 55% of pathologists will agree, by the way, based on the research. But maybe you do actually have chronic endometritis or even acute endometritis. So now what do? Well, you still don't know. Do you take doxy? Do you take flagyl? Do you take moxifloxacin, clavulin? Like, which one is for you? You have no clue. All you know is you have endometritis. So those tests are useless. You need a next generation sequencing test, which we currently use for Fertility because I don't trust anyone else. But in a couple of weeks, we'll have our own, I hope. And so we're just finishing off validation. And as soon as it is commercially ready, you'll be able to come here and do that test or send it in. And we'll be sending packages all over the place for people to do that. Plus, ours is different from what anybody else offers because we have a special feature with it, which no one else does. So I'm really excited about that product. Yeah.
May I ask you a double trigger of HCG Gonasi on a natural conception cycle? In what way would you do it?
In a natural conception cycle, I wouldn't do it. Your body's probably the best judge of when to trigger, and you probably don't need a double trigger. But if you were going to do it, 18 to 20 millimeter follicle, take your Ganassi and take your HCG, and then have sex 36 hours later.
Back to TikTok, Dr. V.
Uh-huh.
After a 4-year wait, I am now pregnant, and this is thanks to Dr. Victory.
I love that stuff. Like, that's just gold on live.
Absolutely.
That's amazing. Yeah, congratulations. I have no idea who you are because Tarek hogs all the computers.
I hog all the screens. I am a super duper screen hog. Straight up.
All I see is the camera, folks. But congratulations. That's amazing. Very happy for you.
For everybody online watching right now, I think the liking of the live, you know, the problem is we show up on a Monday. People are like all scattered about it. They're like, oh, Dr. V, why are you here on Monday? My whole life is around Tuesdays.
We got a department meeting tomorrow that I can't miss.
Oh, of course. Guys, if Dr. V is going to ever miss, it's for something super duper important.
It's for something important, yeah.
Does a high BCL6 positive indicate endometriosis? I've had 3 failed transfers before knowing this.
I know. I needed the drama with that one. Yeah, BCL6 is useless. Don't do BCL6 testing. It's completely nonsensical. Waste of time, waste of money. Don't do it.
After my little gathering, it wasn't even my gathering, it was my wife's gathering. But after that gathering, I'll be honest with you, I'm like, I feel pretty confident that I'm a real doctor at this point. Because you have to imagine, for women to ask a question to a guy about their period,
that's a lot.
That's a lot.
That's a lot.
And for them to not go back to the doctor, for them to basically say, this guy's an idiot, I need to ask someone that knows something.
Yeah.
And somehow they land on me. God knows.
So I said something today online, and I'm going to stand by it. A little controversial, but I'm going to go there, okay?
Go there.
I think women are tougher than we are.
That's definitely controversial.
Even you might find this controversial.
But I'm willing to hear it out.
Hear me out, okay? I do the craziest surgeries, like gore, blood, brutal C-section, cesarean hysterectomy. You're literally covered in blood. I've taken out cysts that were so big they wouldn't fit in a 5-gallon bucket.
Oh my God.
I've literally taken out cysts so big that they wouldn't fit in the 5-gallon bucket.
Oh, that's humongous. Okay?
So, I've done the crazy stuff. I've operated on brain. I've operated on bones. I've done heart. I've done lungs. I've done, everything GI and gynecological.
You're all in there.
Surgery. I am all in, right? 100%. But you take my blood, all right, and I am down for the count, man. I hate it when they draw my blood. I feel woozy. I can't look. I don't like it. today was probably the first time in a long time that I didn't actually need to lie down when they did it. I said, like, you're a grown boy now, like, tough it out.
Is that right?
Okay, so here's the kicker, okay? The women that come in here need like 14 or 16 vials of blood when they were doing their initial blood test.
Mm-hmm.
And they never say a peep, okay? They plow through it, they're fine. The really, really gentle ones, maybe they need a little Gatorade or a chocolate or something, but like it's genuinely rare, okay? I don't like my blood being drawn. I pass out when I get my shots.
No way.
Oh yeah, going down. You give me a shot, I'm cool.
That's hilarious.
I freaking hate it. And I'm not the only one. So many of the guys that come in here, we draw their blood.
Out. Oh my God.
We had one just the other day again. Like, the women, once like in a blue moon, the guys, we all go down. Like, just.
They are stronger in some things for sure. They are. I don't know what it is.
There's a resilience in women.
There's a resilience.
Yeah. And you know what? It shows when they're going through fertility. I'd argue fertility, cancer, probably, I'm not going to put down anyone going through cancer, but like fertility journey is rough, right? And as guys, like, let's be honest, our contribution is kind of easy for us. It's kind of fun for us. But like the women, they're no question, they're carrying the brunt of this journey, right? And the fact that they just show up time and again, they bury the tears or they dry them up, they gird themselves up again, they go through all this blood draw after blood draw, invasive wand up the woohoo after wand up the woohoo, and they keep a smile on their face and they still go home and be a wife and be the mom and be the dear and help clean and cook and do whatever it is that they do. Like, hey, more power to you, right? Like, I couldn't do all that. I pass out when they shoot me with the damn needle. So ladies, thank you for being you. Maybe a bit controversial, but it's something.
I don't think it's controversial when you put it like that.
Yeah.
I don't think it's controversial. Because initially when you thought stronger, I was imagining somebody carrying a car.
No.
I said, no, Dr. V, don't make me disagree with you on live TV.
You're strong. You're strong.
I'll agree 100%.
Yeah.
I'll agree 100%. But that is probably controversial. But that's the hot take Dr. V's dropping today.
But it's true.
It's true for sure. It's true for sure.
They carry a load you and I'll never understand.
Well, I'll tell you one thing. Anytime I'm actually sick, like if I'm sick,
yeah,
I don't know exactly to what severity my sickness is. Like you can never gauge man's sickness versus woman's sickness.
Yeah.
But I always feel that when I'm sick, I'm dead. Like it's over. I'm in my bed. I'm not getting out. It's over. Like
man cold.
It's over. Whereas when my wife's sick,
yeah,
she looks healthy. She says she's sick. She says she's tired. She says this. She says that. But
she's plowing through.
She's doing stuff.
Yeah.
Me, if I'm sick, so I don't know if it's like my tolerance to when I admit I'm sick is different.
Yeah.
Like maybe that she's like, I got a sore throat, hence I'm sick. Versus me, I only admit I'm sick when I'm almost dead. Like kidney stone, I'm about to go to the hospital. I think I'm sick.
Yeah.
You know what I mean? So I can't gauge that. But I know when she says she's sick, she's doing stuff. When I say I'm sick, my kids don't even see me. Nobody knows where I am. I'm just in bed hibernating, trying to restore my energy. Real talk. Kings.
Like that, yeah.
Can you do excision in the middle of a 3-month suppression window? Or would that lower chances of the FET success? Lots of debate on this. Lots of debate.
It increases your chances of success because you're maximally suppressed. It's easy to get rid of the endo. You go in there, you clean it up, and now you're ready to go. Party time.
Party time.
Yeah.
Back to TikTok.
Is the camera on you or me?
Right now it's on you. You want it on me? I'll put it on me.
Excellent. Yeah.
There you go.
Go for it.
From Texas, USA.
Texas. Love it.
Hello, doctor.
They got snow in Dallas. That's how bad this snow
is.
I
know. I heard it was
Dallas
insane.
got like serious snow.
Yeah.
That's next level. Hello, Texas.
So after failed IVF, IUIs, and miscarriages, will we be able to figure out why lining is weak?
Yeah, sure. Half the time it's the shape of the uterus. I see all these people, they come and they go, my lining never thickens. I'm like, 3D saline infusion saw on Instagram, never got one. I'm like, what do you mean you never got one? No, I never got one. They did a hysteroscopy. I'm like, show me the pictures. I literally had a picture from someone in the U.S. I said, show me a picture of your uterus. She showed me. I'm like, your uterus looks septate. She's like, what do you mean? I said, like, look at it. It's right there. It's really prominent. It's indented. She's like, what do you mean? I said, like, I mean, I'm telling you what I'm seeing. It's right there. And it's really narrow, too. She goes, well, they never told me that. I'm like, oh, my God. How? It's just like maniacal. So, when you pay attention to the details, you make a difference. When you don't pay attention to the details, you're everybody else.
That's it. To the O'Neill and Bryant of the fertility worlds. Do you get that reference, or is this super normal so far?
I do. I forget who they are, but
Update on Kappa IVM trials and euploids yet? If so, age of patients.
Not yet, but we're just starting everything, and so we're not there yet, folks. We need lots and lots of patients. We're just starting the Kappa stuff, so it's just underway.
People are super excited for that, eh?
I know, it's crazy.
Ultimate game changer in the world, happening right here.
It will be the way of the future. I'm convinced because the egg quality we're getting, even from like really older women, phenomenal.
Oh, is that right?
And we think we have an idea of what we need to do to get the aneuploidy problem solved.
Mm-hmm.
So if that works for us, that would be next level. And so we're going to try some really cool things.
Some moves.
We got some moves.
3 failed IVF cycles with 0 blasts, Dr. V.
Jeez.
Adopted embryo transfer failed.
Oh.
Endometriosis finally found. Going for excision surgery now. We have 1 more adopted embryo. Tips for transfer. Thank you.
Endo protocol, immune stuff, lots of healthy diet, focus on improving intercourse beforehand to maximize endometrial receptivity. I mean, I got a laundry list of things you could do, but
can I suggest something?
Thyroid,
can I be sure. Like a little bit of a strange comment? And again, this comment can very easily be corrected by Dr. V. So if I'm wrong, I humbly apologize. But I feel it's just part of the conversation today.
Now you got my interest.
You know what I mean?
I'm all ears.
So she's saying that she did 3 fails and 0 blasts, adopted, transfer, endo, and she's on her last adopted thing.
Okay.
Assuming the age and everything else is okay, I don't think she should have the sentiment of all hope is gone, because she found out what the main problem is, right? Yeah. It's the endo. So technically speaking, and this is a real hot take, maybe the adopted embryo wasn't necessarily necessary.
Yeah.
Because the endo problem was really the problem making all the problems. Dr. V?
If there was a way to like knight you or something, I would. Yeah. Here's a sword on this shoulder and that shoulder.
I accept the knighthood.
Yeah, that was the doctorhood. Yeah, that was very doctor of you. Good job, buddy.
You see that?
Yeah, so I completely agree with you. I mean, they missed the initial diagnosis 3 times in a row.
3 times in a row.
There's this huge aversion for doctors to actually diagnose women with endometriosis. I actually fundamentally don't understand it. The honest part, I think, is that there's a lack of education. I think there's a lack of knowledge. I think there's not necessarily gaslighting, although that probably happens sometimes too, but I think there's this tendency to downplay the, pain. And, you'd think that like female doctors would be better at being sensitive to that than the male doctors are, but we're all equally not great at it, right? And so unless you're someone who really believes in endo and you can pick it up easy, the rest of the crew is not doing that. The cynical part of me says, well, like, a lot of these clinics just want to make money. And when you have endo, I can tell you ahead of time, like, you're going to need more tries. I know that for sure. It's not going to work necessarily on first try. You might need 2 where someone else would need 1, or you might need 3 where someone else would need 1. Or if you have weak ovaries, now you need multiple, right? So am I really keen to go and operate on your endo and get rid of it all? I am, because I want to optimize people's results. But if my goal is to make money, hell no, I don't want to do that. So, like, there's this weird very tangled web of reasons and rationale for why people don't get diagnosed with endo. Like, it's insane. If you look, if anybody at all fails an IVF cycle, right? Don't you want to know why? Like, I cannot tell you how many people I speak to and I say, like, what happened? I don't know. Like, what was your egg quality? I don't know. What was my sperm quality? I don't know. Like, they have no clue what happened. And they're getting a invoice for the next cycle before they've even been told what happened in the previous one. Okay. As a physician, if I have a cycle that fails, I'm immediately saying, well, why did it fail? And I want to know the details. Even if it's not a whole cycle, one or two embryo transfers, if it doesn't work, I want to know why. Is it an immune problem? Is it microbiome? Is it endo? Is it adeno? Like, is there something wrong with the uterus that we somehow missed? Let's repeat stuff. But to just throw your hands in the air and say 3 cycles, oh, it didn't work, and then go find out the patient has endo, that's a WTF if ever there was one, right? So I don't get that. Like, to me, it just doesn't make sense. We need to do a better job for the patients.
If you could only afford to do one, would you do female microbiome or diagnostic hysteroscopy?
Okay. If you're looking for endometritis, I would do the female microbiome because the hysteroscopy is useless. If you're looking for a problem with the uterus, I'm going to ask you why you need to do hysteroscopy, because almost every single problem with the uterus can be detected with a saline infusion sonohysterogram, which shouldn't be nearly as expensive as a hysteroscopy, does not require anesthetic at all, and if done properly is painless. So, I mean, I would start with that and then put your money into your female microbiome, because if you're looking for endometritis, like I said, if you're looking for a problem with your uterus, just do the SIS. Now, granted, if it's an American person asking this, the difference in cost is roughly 3 to 4 times to do an SIS in the US compared to what it costs to do it here.
Wow.
Yeah. So it's like 900 to 1200 US dollars, and it's 450 Canadian, which is roughly 300 US.
Sometimes Canada's got gold, right? Sometimes Canada's the winner.
Yeah.
Wow. Hello, with a wave emoji. Is a dose of 2.5 milligrams of Omnitrope considered high in IVF protocols? Are there standard or typical dosing ranges? And is there any risk of ovarian hyperstimulation with this dosage? Thank you.
That's a normal dose. There are dose ranges. We go lower than that, but we never go higher. I haven't seen too many studies that went higher, so I would probably stick to that. Is there a risk of ovarian hyperstimulation? If you're needing human growth hormone, your risk of ovarian hyperstimulation should be low, because we use it mainly for women that have diminished ovarian reserve. So it would be somewhat shocking if you developed OHSS, but I'm going to be careful and say there is always a risk of developing OHSS, and therefore your doctor needs to be very aware of what's going on and cognizant of how to trigger properly and how to avoid OHSS. So is there a chance? Sure. But is it common? I mean, that's got to be negligibly low.
Ready for this one?
Well, it depends. I mean, these days you never know what's coming my way. So yeah, go ahead.
DOR
Okay.
38.
Okay.
4 rounds of IVF.
Wow.
4 embryos. None PGT tested.
Oh boy. Okay.
None pregnant.
Right.
1 miscarriage at 7 weeks after hearing a heartbeat.
Oh, I'm so sorry.
What are the chances of silent endo?
Oh, wow. Well, that's a tough one. 38 with DOR. I mean, I'd say with that history, all those failures, significant. 50%, I would guess, somewhere in that range.
I would actually say 90%. I would bet my money on it.
That might be brave.
If I were a betting man,
yeah,
and I'm not.
Yeah.
But if I were a betting man,
it's against your religion.
Yeah, that's right. It's against my religion. But let's say for one day it was like, hey, would you take these odds?
Yeah.
I would absolutely take these odds of endo.
Yeah. I would.
You would too, right?
Yeah, I mean, statistically speaking, I'd say 50, but I got some questions there. I mean, why did you fail?
So many times.
That's right. Scary.
That's right.
Oh, it wasn't PGT tested. Okay.
It wasn't even PGT tested.
Yeah, but you're 38. Why do you have DOR?
Yeah, even the DORs to me sounds like an endo.
Yeah, it's possible. I would say likely.
Yeah, the 99%. That's my non-medical opinion.
I'm really liking tonight. Let me tell you what. I got Marla now doing the business side of things,
right?
Or at least management. I've got Lisa doing the business part of things as well, development stuff. I've got Mara running the show, Wendy and Monique doing all the backdoor financial stuff. I've got Stephanie helping me out and Shireen. And now you're taking over the medicine. I'm getting to that point where I could just not show up.
We're just going to sip coffee together. Just sip some tea together. That's what it is.
This is getting really good for me. I'm really liking this.
See, everyone's a student of Dr. V. That's right. Hi, Dr. V. What tests would I do after a D&E if I want to try again? Should I test my microbiome right after a terminated pregnancy, or do you recommend trying embryo transfer first?
Well, first of all, I'm sorry you had to go through a D&E. That's terrible. I would do definitely a saline infusion sonohistogram to make sure there's no scarring, because it's a procedure that comes with a high risk of scarring. But assuming there's no scarring, I don't know. I mean, I'd probably say you're okay to skip a microbiome unless there was retained tissue or something like that.
From YouTube. Hi, King and Doc. And now I don't know who's who. Now I don't know. I'm going to assume.
I'm pretty sure you're still king.
I'm pretty sure I'm still king for sure. This is authentic titles here. What should you do for the next 3 to 5 days after an FET? No sex, walking, limited activity. What to do?
Well, you should have sex. That's proven to be beneficial. Maybe not 50 Shades of Grey sex, but sex. You should do whatever relaxes you the most. You should walk if you want to walk. Just don't do super heavy exercise or anything like that. Kind of moderation in everything. Don't overdo anything. Don't go have a banana split, but if you want a scoop of ice cream, have a scoop of ice cream, right? So, pretty common stuff, just be normal. The one thing I'm going to ask you, because I actually had a patient and this just blew my mind recently, for the love of God, don't go test. We had a patient that started testing 5 days after, was negative, and then said, "Can I stop my meds?"
Oh my God.
I was like, what?
Oh my God. No. Not even 2 weeks. 5 days.
Not even 10 days.
Oh my God.
Into it, and she's like,
I'm done.
No, you cannot stop your meds.
Oh.
Yeah. Crazy. So, don't test. Please, for the love of God, don't test.
You ready?
No test that's going to be that sensitive. Not even blood work will pick it up.
Nothing's going to pick it that fast. Does a high BCL6 positive? No, it's a different one.
Okay. Is it?
Mm-hmm.
Is it predictive of endo?
That's in there, but there's more.
Okay. All right. Go ahead.
Maybe same, maybe different. I can't tell because there's an added nugget here that I think you'll enjoy.
Okay.
Does a high BCL6 positive indicate endometriosis? I had 3 failed transfers before my Receptiva DX.
Oh God. Listen, BCL6 is not proven to be beneficial. Having said that, if you've had 3 failed transfers and you have a positive Receptiva, you should definitely be evaluated for endo. Would I do it on the basis of the BCL6? No. Would I do it based on your history, examination, ultrasound findings, your history of failed multiple embryo transfers? Yes, I would.
Oh, this is interesting. So that question is here. And then on TikTok, it says, why not do BCL6? What's the alternative?
laparoscopy.
That's the only real way.
Well,
And I think people got to get that.
Yes and no. I mean, like I can look at people and say you have endo, right? Like, and I'm
Based
right.
on symptoms, right?
Yeah, and I'm right most of the time. So, I think a good clinician should be able to figure out if the patient has endo.
What's the percentage of silent endo to real endo? Like, and silent endo being like zero symptoms, like completely unable to detect.
Yeah, between 25 and 40% have silent endo.
So they're completely normal on all sort of ways of gauging normality. No way.
Yeah.
Period's normal. Everything's normal.
I've said this story before, but the worst case of endometriosis I've ever seen had no idea that she had endo. None. And I could not tell what was what in her pelvis. I called in a general surgeon to help me because she wanted a hysterectomy. I had to call in a general surgeon because everything was just cemented together. Okay. It looked like someone had launched a grenade into her belly or detonated a grenade in her belly. And then they felt really bad, so they poured crazy glue in there, and everything just like mushed together. Like you couldn't tell what anything was. We did a hysterectomy. It was so bad the general surgeon said, I cannot do more than what I've done. Like they just did a minimal amount and said, this is as far as you're going. Like chop the uterus off here. This is all you're getting out of it. And I woke her up and I said, like, why didn't you tell me? She goes, tell you what? I said, like, how bad your endo was. She goes, what do you mean? I don't have endo.
Oh, wow.
She had no clue. No clue. I said, painful periods? No. Painful sex? No. Like heavy periods? She goes, yeah, my periods were just heavy. That was it. Just heavy periods. That was all she had.
But isn't that a good symptom? Or like, what percentage is that?
One of them. I don't know that there's a percentage like that it'll predict endo, but it's one of the symptoms, but it's not the only symptom.
Mm-hmm.
And it's not one of the 3Ds. Dysmenorrhea, painful
right.
period. Dyspareunia, painful intercourse, deep pelvic pain. Heavy period is not one of them.
Maybe it should be added to the list.
Yeah, we talk about it as fertility REs, gynecologists, because we know it's in there, but it's not like one of the classic diagnostic.
Interesting.
Yeah.
I think that diagnostic needs an update. Tarek's dictionary will update it.
It definitely needs an
right?
update. Yeah. Yeah.
For immune testing, Dr. Victory, what types of tests is that? And assume my doc will know. Any recommended microbiome testing? When you recommend closer look at uterus, would that be hysteroscopy? And do you recommend biopsy for endo?
Wow, that was a lot of questions.
Yeah, there was a lot of questions.
Yeah, so the testing we recommend right now is Fertility. Just ask for Victory Panel 1 if you've had recurrent implantation failure, Victory Panel 2 if you've had recurrent miscarriages. It'll give you all the immune tests and all the microbiome testing that you need. The hysteroscopy, I don't advocate for hysteroscopy, even though we have 4 different hysteroscopy setups here, unless patients need it. And you only need it if you need surgery. So that's what I would suggest for that. You're way better off doing a saline infusion sonohysterogram, cheaper, no anesthetic required. Painless, simple, no risk whatsoever at all. And then no one should do an endo biopsy. So please, for the love of God, do not do an endo biopsy. They're useless. They're totally useless. It doesn't tell you anything. Stop doing it. If you have endometritis, it tells you have it and you don't know how to treat it. And if you don't have endometritis, it literally doesn't mean you don't have endometritis. So you're no better off than you were before you started.
Dr. Victory, how do I connect with your clinic? I am in desperate need of help.
Well, you can go on the wonderful website Tarek made for us, which we need to revamp again. And you can book a consult from there. You can contact info@drvictory.com and you can do it through there, or you can call the office, or if you're in Ontario, you can get your family doctor to refer you. There's all sorts of options.
I have 2 untested embryos left. The doctor suggested to implant both. Would you recommend that?
I need way more details. I need to know how many times you succeeded, how many times you failed.
It sounds like when they said I have 2 left.
Yeah.
That they've tried more than once.
Sure, but I mean, I don't know how many times they tried. How old are they? What's their BMI? What are their finances like? What's their health like? Are they going to tolerate a twin pregnancy? We don't do a lot of double embryo transfers, but we do. It depends on the history, right? So I need to know all that before I will concede to doing two.
I think you should tell them about figuring out what's wrong before you drop it in there.
I agree. I mean, why are you doing, what happened before? Again, that's what I need to know. I need to know all the details. What happened? What testing have you done? What kind of things have they looked at? Did they look for endo, adeno, shape of your uterus, microbiome, immune testing? Like all that stuff needs to be looked at. Tossing in more embryos is the fastest way to getting you to pay us more money. That's not a good plan.
My fertility doctor, I guess that's not you.
I hope not.
No, because they would say you, right? My fertility doctor told me that stage 1 endometriosis does cause severe inflammation. Is this true?
Does or does not?
Does.
Yeah, of course it's true.
Currently doing suppression. I have to do a medicated transfer. How much estrogen do you recommend?
As little as humanly possible. Start with 1 milligram and go from there.
What cycle day would you do a Neupogen wash for transfer to be most effective?
5 days before transfer is what the research looked at.
Dr. V, is a 9,475 beta good for 6 weeks pregnancy?
Could be. I need to know more details, but it's a little on the lowish side, but I need to know details.
My fertility doctor told me that, we did this already. How do you decide 2 versus 3 months of suppression in endo?
Severity of the endo. I love rapid fire.
I know you do. I know. Is inflammation always visible with a hysteroscopy?
No.
Oh, going back to the dumping the two embryos into the person, both embryos are a 3 CB.
Oh, yeah, I would put both of those in. The chances of success are unfortunately low.
I have stage 4 endometriosis, failed IVF. Can I do another IVF?
Can you? Yes. Should you? I need to talk to you. I mean, should and could are two totally different things, right? So, can you do another IVF? Yeah, absolutely you can. Should you do another IVF? I don't know. I need to find out more about you. Why did you fail? How many eggs did you have? How high was your stimulation? Did they fry your eggs because they thought giving you mega doses was going to help when your AMH was 0.5? What's the sperm quality like? Did they manage to access the eggs? The other day, we had a patient with 2 big endometriomas. Okay, I performed some sort of ninja mystical
I like it.
needle positioning, including an abdominal retrieval, to manage to get to her eggs without hitting those endometriomas. Are they doing that for you, or are they going, oh, sorry, we couldn't get the eggs, we had to leave them because it was too risky?
They're doing that one.
I don't know, but I need to find out before I tell you should you or
should you not.
Yeah. 9 o'clock.
Last one. I got a good one. I think it's pretty good.
Give me a good one.
It's not big. It's just good.
All right. Put the camera on you.
Sure, because I think it's a very unique question that I've never heard before.
All right.
I think you can give this a great response, is my humble belief.
All right. I'm all in.
Hello, Dr. V.
Yeah.
What is your opinion on 3 to 4 hour abstinence interval for a high DNA frag?
A 3-hour abstinence interval has been clinically proven to reduce your DNA fragmentation by 80%. So that's a no-brainer. It should be done. We've been talking about that forever. So if you ejaculate and then ejaculate 3 hours later again, the second sample, 80% reduction in DNA frag in the one study. And with that, ladies and gentlemen, we will close the show. Thank you for joining us on Fertility Fact or Fiction. To all our friends on YouTube, Instagram, Facebook, and X, thank you for joining us. And we're going to try and add in LinkedIn soon, or I might kill Tarek. And to all those on TikTok, thank you for joining us on TikTok. It's been a pleasure to serve you guys. And I'm very, very proud tonight to know that another doctor gave up and referred to us. That's hardcore.
That's the best.
That's like
big fan,
man. I love that. Yeah. So thank you to whoever that doctor is, and in an effort to remain somewhat humble, I will say that I have a great relationship with a couple of other doctors that I reach out to when I'm stuck on what to do. So, you know what? It's not all about us. Sometimes having a great team makes a difference.
It's good medicine when you ask colleagues.
Yeah, it is good medicine.
Absolutely. Because if you don't know it, why are you faking it?
Yeah, yeah.
It's literally my life you're faking with.
Yeah, yeah. I don't want to do that. I want to ask. Yeah. Have a good night, guys. See you next week on Fertility Fact or Fiction. It should be next Tuesday.
Tuesday. It should be Tuesday.
It'll be Tuesday. And please bring all your friends who want to argue that induction of labor at 39 weeks is not the right thing to do. Anybody watching the show, next week, we will be talking about why you should be induced. I'm going to go to town on it. Lots of controversy.